Great, thank you. Good evening, everyone. This is a meeting of the Northampton Board of Health on December 18th, 2025. Um, this meeting is being recorded. And before actually entering the meeting, we'll ask if there's anyone here for public comment. If anyone would like to make a public comment, please raise your hand on your Zoom screen.
Joanne, can you hear me?
Oh, yes. Excellent.
Oh, I got about six different screens open here. Okay. But
We
I,
only
I
see
can't
one of you.
I
But
can't see you. You can't see me, but I'm listening and you can hear me. Let's go.
okay, we're going. So we're just looking for public comment. Is there anyone here for public comment? You go down on the Zoom menu and raise your hand. Raise your Zoom hand. I don't think there's anyone here for public comment but I don't know everyone. So I think not. Okay, then we will move on. So now we'll open before we open the Board of Health meeting, I'll just introduce the members who are here, and then Michelle will ask you to introduce their staff and visitors who are here. Tonight we have Dr. Cynthia Swopis, Dr. Suzanne Smith on audio only, Janet Grant, and me, Dr. Joanne Levin. Michelle Ferry, Deputy
Deputy Commissioner.
Commissioner. Thank you.
Fancy.
Why don't you introduce who else we have here?
Sure. Here tonight we have from the DHHS Director Amy Hutchins of Environmental Health, Director of Prevention Taylor McAndrew. We have Kelly Constantine, who directs us all in the Department of Health and Human Services. Then we have our very excited and prestigious guest from the UMass Center of Program Evaluation, Professor Jennifer Whitehill. We have Amelia. And Amelia, I don't know how to say your last name. Can you say it for me?
Yes, it's Zance.
Zance. Oh, it looks so pretty on the screen. We have Ariel Scalise, I think. Scalisi?
Scalise, perfect.
Phillies, all right, great. And then we have Nora Finnerty. And I just want to say Nora and Jennifer have been leading our project for UMass CPE for almost 3 years. And we are very grateful to have Ariel and Amelia, who've joined us in the last couple of years in this project as parts of their academic studentship with UMass. So it's very exciting for us to have this four-person team. And I will stop
And
there.
Amy DiCaprio.
Oh, Amy, did I say? I'm so sorry. And we have Amy DiCaprio, who's one of our most beloved staff members at the DHHS.
Okay, we'll start by asking if someone would like to make a motion to open the Board of Health meeting.
To open the meeting.
Second.
Any discussion? All in favor? Cynthia?
Yes.
Janet?
Yes.
Suzanne?
Yes.
Joanne? Yes. Okay, and the meeting is open. It's 5:41 p.m. Take it away.
So tonight, Jennifer, I'm going to hand it over to you. I just want to say the DHHS has a pleasure and the joy of developing a partnership with the UMass Center of Program Evaluation, which they're going to talk about some of that background and history. And this is part one of what will be a two-part presentation, with the second part planned ahead, likely for March, to be determined, and will be announced ahead with a Board of Health meeting agenda for that month. Dr. Whitehill has been, I just called you Dr. Jennifer, and Professor Jennifer Whitehill and her team have been instrumental in the launch and the expansion process of the Division of Community Care as part of DHHS. And what we're showing you here goes back in time, which she'll explain, but as part of this process and being with us before the DCC launch, they've had the pleasure and the lens of seeing all of this growth from the very early inception. From actually, I remember communicating, I think, before I even got on that plane to Portland or shortly thereafter. And so this is a very exciting reveal for us as the first part of the public assessment and evaluation presentations to be given relating to this work. So thank you, Jennifer, for taking this on tonight with us.
Well, thank you, Michelle, for the intro. I hope everyone can hear me okay and can see our slide deck. Um, I'm Jennifer Whitehill, and I will apologize for my camera that gets some blurry sometime. It was one of those early COVID pandemic purchases, and I think, 5 years hence, it's starting to say, but more than that, like enough. So let me know if things get weird. I'll probably be focusing on my slides and what I have to say. Yeah, my name is Jen Whitehill. I am a member of the faculty at UMass Amherst in the Department of Health Promotion and Policy, and I have the privilege of leading the evaluation of DCC on behalf of the UMass Center for Program Evaluation. We are going to talk tonight, which in part one of our two-part presentation, about some of what we've learned so far. As Michelle mentioned, we have had the privilege of collaborating with the DCC for quite a few years now, and I'll talk a little bit about the timeline and start to share some of what we've been seeing for the particularly baseline and sort of early phase implementation activities is what we'll talk about. I need to give a quick shout out to the awesome team at the UMass Center for Program Evaluation, which we call CPE. If we start to go down, if I go down academic jargon, that's what that I know in government, people like their abbreviations too. This is our team, and over time, we have had roles from a number of different people, and it's been a real pleasure to also get to incorporate some students into our work, and some students have transitioned into staff members. So that's also exciting to see. The point I want to make is that although I'm speaking tonight, this is a big team effort, and I want to give a big shout out particularly to Nora and Amelia, who did a big lift to help get ready for tonight. So tonight's presentation is, like I said before, part one of a two-part series that we'll do. And today I will give a little bit of an overview of the UMass and DCC evaluation partnership so folks understand, what we're doing. And I'll share a bit of the lens that we use at the CPE to come to evaluation and implementation studies, because I think that sets us up to make sense of the 7 different types of data collection and assessment that we have done over the last 3 years. We'll have time, I hope, to talk about 4 of them tonight, and we will save 3 of them for next time. Yeah, that's the goal. We'll see if we can get all the way there while also not making everyone's eyes glaze over. And we will have a Q&A at the end, so I suppose it'll be helpful to hold comments for the end. Okay. So just to start and set the stage, this is an evaluation of the DHHS Division of Community Care, right, the DCC. And since it might have been a minute since you've heard a presentation about the DCC programmatically, I'll just remind folks that this is an alternative community responder program that's responding to nonviolent and behavioral health calls. They provide de-escalation, emotional support, advocacy, and support with navigation and connection to resources. Proudly, as you can tell, housed within the Northampton DHHS, the DCC really centers a public health approach. And that's different than other programs that are similar that may be located within other kinds of government agencies or outside of government. The goal here is to complement, not replace, existing first response services like police and EMS. And we'll talk about some of what we've learned around the complex task of standing up a new entity within government. So I want to emphasize, by way of background, that what the DCC is doing is part of a broader national trend towards community responder programs. More and more places are putting things like this into place. But there's a big range of what those things are. Michelle mentioned going out to Portland to learn from one kind of existing program. There's a number of different things, but things that are shared across these kinds of programs are the goals of reducing unnecessary law enforcement involvement in nonviolent crises, providing appropriate supports that may be more appropriate, and improving equity and trust in public safety and public health systems. So we'll think about these kinds of overarching goals as we talk about what the program is doing and what we're learning about it. The goal of our evaluation in particular was sort of four-pronged. We've done a lot of things and they fall under these four major headers. First off, there was the goal of assessing development, implementation, and the early impacts of this novel municipal program. We wanted to understand how the DCC is integrating into the emergency response and greater social services landscape in Northampton. Part of that is identifying facilitators and barriers to success. This is a complex thing to do. And so by having evaluators at the table really early on in the program's life cycle, there were opportunities for an outside lens to ask questions, not only about outcomes that everybody would like this program to get to, but how we're getting there. And we'll talk a little bit more about that. What that meant was that we had an opportunity to provide ongoing feedback that can help lead to improvements and sustainability. We co-designed the evaluation with the DCC and the DHHS leadership, but we also seek to maintain our role as external evaluators as much as possible, providing objective analysis and evidence that can inform their decision-making. And I'll just say at this point that the commitment to being willing to hear an outside voice, share sort of strengths and challenges is something unique and rare in my experience, and something that I think the city should be really proud of in terms of welcoming folks in like this to bring in that outside perspective. For tonight's talk, I will focus on three different pieces of evaluation work, right? Evaluation means a lot of things, actually. We might have our instincts about what we think it means to evaluate something, but I want to be really clear that what we've done here involves three primary aspects that we call formative evaluation, which was understanding, how the DCC was formed as it was being designed. Formative evaluation can inform that early phase of planning and what is this going to be. Process evaluation is an ongoing piece that helps us understand how the program is operating in practice, what's really happening on the ground. Outcome evaluation helps us look at results such as changes in service and use and community perspectives. I don't know if you guys can hear the students talking loudly in the parking lot outside my open window, but it's move out time at UMass. Anyway, so we use these different lenses for evaluation to have a layered picture of what means to the DCC or any program that we're evaluating. How are they doing what they do? Because we know that at the end of the day, you can measure whether or not something happens. But if you don't know how and why, you're really limited in terms of thinking about improvements. So, and we use both quantitative methods and qualitative methods in all of these types. The larger lens that we bring to this is actually called implementation science. And I would not be the instructor of it, but my colleagues teach entire courses on this topic, right? It's such an important part of doing things and making change in health systems and other systems. So in a really high level, I'll just share that this is a science that focuses on how programs are adopted, implemented, and sustained in the real world. it can be pretty different than the good idea that an academic has about what should happen or the demand that a community has for what they want to see. Implementation sciences focuses on how things work, and brings some frameworks that we can use to think about how a program like this runs. So for DCC, this means paying attention not only to those outcome pieces, but also organizational structures, relationships, and contexts that shape those outcomes. So I'll share this rather busy timeline slide that does show you, 3 years of activity. And I think the value of implementation science can really be illustrated when you think about our blue solid line boxes on this slide that are a small subset of the programmatic activities. What was going on at the DCC throughout this time period? Things like hiring, trying to train the workforce that's going to do community response, integration into Northampton Public Safety Dispatch, a huge milestone for the program. All of these, there's just a few of the many, many things day to day happening. What we then do is layer in the UMass evaluation activities, which are reflected by the red colored dotted lines here, where we were able to, at different time points, find out different kinds of information that lets us understand the way that this program is going from that lens of different kinds of evaluation. So I will make these slides available afterwards if people want to take a deeper look at this timeline. But the main idea is that the program staff are super busy making decisions, trying to figure out how to build this and run this new thing. You can see why most programs are never actually evaluated, and certainly not with process evaluation that helps understand. All of these blue box decisions have real consequences for the outcomes, and it's a pretty rare thing to get this kind of deep knowledge about it, outside of interventions tightly controlled in academic settings. So this is, again, something that the city should be really proud of. I think it will have a lot of strength for how the program develops over time. So tonight, we're going to focus on 4 particular pieces, summarizing 4 particular things that we've done as evaluators. That's going to include, and they're color coded here, so you'll see these colors kind of coming along through the presentation. We'll talk about a community survey that we did at baseline. The community partners that we also did what I call baseline, or 2 things that happened before the DCC formally launched. Those fall into that formative evaluation category. And then we'll share 2 pieces of the process evaluation where we talked to, in qualitative interviews, DCC's workforce of community responders, as well as interviews with clients. And I suppose this is the teaser part of the presentation, but next time we'll come back to you and talk about 3 more really important pieces of the analysis that are getting wrapped up, which included interviews with other municipal emergency response agency personnel, an analysis of the 911 dispatch data, as well as some work with the DCC client records. This is a very comprehensive set of activities that I think, taken all together, will help the city really understand what's happening with this program, not only what the program's doing, but also with systems level changes that are needed to support this kind of program. Okay, so diving in, I'm first going to talk about the baseline community survey. So this happened in 2023, and where you see baseline at the top of my slides, that's telling you that this was before the DCC opened its doors to clients, and that's really important to keep in mind. The goal here was to understand the Northampton community's readiness, sort of demand and context for the DCC prior to its launch. So again, this happened before it opened. With the goal of providing baseline data about things like how much awareness is there of the DCC? What are the community priorities and concerns? What are the community's preferences for who would respond to different types of calls, and to provide a baseline against which future measurements could make a comparison. That's really important in evaluation kind of work. So to have more than just a one snapshot perhaps down the road, but to have a baseline to compare to. The methods for this piece of our evaluation work were to utilize two different recruitment methods to target adults over 18 living, working, or receiving services in Northampton. We used both an online survey that was disseminated through community groups and web pages and email lists, as well as a street intercept survey where members of our staff stopped folks in busy locations and tried to recruit them to complete a short survey right there. This is a really useful technique to reach harder to reach groups. And we know that that really matters for trying to understand something like the implementation of the DCC. In all, we had 475 responses. 55% from the online survey and 45% from the street intercept. So the first thing, anytime we're going to talk about these kind of quantitative findings is, well, who are you talking about, right? Who did you talk to? So here you'll see over my next two slides, information on the participants and who participated in this. And you can see that here you see the age group as well as race and ethnicity data. And you can see we had a pretty nice span across the different age groups, generally 10-year brackets here. There were not so many in the under 20 category. The survey was limited to 18 and over. So, that is part of it. And also for a city like Northampton, we think that this probably provides pretty good representation of the year-round non-student population. I also want to highlight that the sample was more racially diverse than Northampton's 2020 census profile. And that's really important for capturing a wide range of experiences and needs. This helps us interpret the findings and ensure that we're not only hearing from one particular segment of the community. We also share here on the next slide some information about how folks reported in terms of their gender identity. And I also want to call out that, we had folks who are employed in Northampton, as well as folks who have lived in Northampton for 6 or more years. So we felt like we were really capturing those who might have a connection to Northampton through coming into work or receive services, or some with newer and some with longer term connections in the community, all of which are valuable here. So what did we find? In terms of awareness and preferences, actually more than half, 56%, had heard of the DCC even before it launched, which honestly, that finding surprised me a little bit. I would have expected, lower numbers. So there was some buzz before the doors even opened, and it was pretty close before the doors opened. And interestingly, 60% of respondents said that they would prefer some type of community response, community responders like the DCC for non-emergency, non-violent calls. We saw some hesitation and I'll go into more detail on this, hesitation to intervene or to contact police in situations particularly related to poverty or behavioral health. So, that really shows the community's desire for something like the DCC. And we also heard that some of the priorities that the community held for the DCC included, provision of resources, quick arrival, and to be really clear, high proportions wanted that if a situation became at all dangerous, they want the police there, right? This is not a replacement situation. This is an nice option to supplement in certain kinds of situations when people may be concerned about contacting the police for fear of, handling things through a law enforcement or carceral approach. So this slide shows the at baseline, the likelihood that people reported being willing to call different kinds of first responders or other groups in these several different categories of non-emergency situations. So this included things like seeing someone asking for money on the street, sleeping in their car, bathing in a public restroom, the kinds of things that people don't quite know what to do about. And prior to having something like the DCC, calling 911 or the non-emergency line is really, or calling a social service agency yourself was really some of the only options. And so what you see here is that most people reported that they were likely to do nothing in those situations, not call any of the existing resources. So again, that helps us understand the demand where the DCC services may be valued. Digging into slightly different data that talked again about these same specific situations and now introduces the possibility of, okay, would you call the Division of Community Care? Would you call the, on my prior slide, calling a community responder wasn't a choice. It was sort of that pre-DCC snapshot. And here we can see that for certain kinds of situations, particularly when encountering folks who might be living in an abandoned or vacant building, or encountering someone yelling or causing a public disturbance. These are the kinds of places where folks reported being extremely, or more than half of folks reported being extremely or somewhat likely to want to call community responders. And we can compare that to those places when without the DCC, people might do nothing, right? They might just not feel comfortable making a call. So I think it highlights the idea that residents can often feel stuck between doing nothing or calling police services, and the DCC offers this additional opportunity to respond in ways that might be more consistent with what the community was saying that they want, again, for these non-emergency situations. Okay, so in academic world, each of these 4 things that I'm going to chat through tonight, if I get through them all, can be a freestanding paper, an entire talk in its own right. So with apologies, I'll keep moving along and sharing some other things that we learned. The next thing I'm going to talk about is our baseline community partner interviews. This was a piece of the evaluation that really wanted to focus on, again, pre-launch, what the key public safety or city officials, other community members wanted to see, and their anticipated strengths and challenges for the program. That really helped to ground what was happening at that early time, but now is a really valuable look back to see what were the partners hoping for and considering as likely for the DCC as it was getting built. So these data were collected in spring of 2023, again, before DCC formally launched. We talked with 11 different people who represented public safety and city officials. And I should say that if anybody here participated in those interviews or other ones I'm going to talk about, we're so grateful for all of that information sharing. Members of the Policing Review Commission. And then after doing these interviews, we took the text of the transcripts and did a thematic analysis. So I'm going to focus here on perceived strengths and perceived challenges, because in 2023, here in 2025, I think these are some of the most useful things to look back and think about that were reported back in 2023. This can tell us whether some of the anticipated strengths and challenges are turning out to be, matching with reality. So some of the things that were potential perceived strengths included reducing police contact during nonviolent crises. That very much aligns with what we were hearing from the community itself. The potential to alleviate call burden on police and EMS. And more people feeling safe and comfortable calling and getting the kind of help that they think is right. Also, of course, there were some perceived, challenges like burnout and turnover, given the nature of this work. The integration into 911 and broader workflows was identified as a potential area of challenge. So was, accountability and how that would need to exist because this is a city agency, while also needing to operate, with some levels of protection for people whose information the DCC might hold, as well as logistical things like the limitation of operating hours and funding. Many of those feel salient today, and we'll revisit that in our next presentation. I'll share just two quotations from some of those interviews. One about the perceived challenges that I think really hits the nail on the head. One participant said, "Well, I think it'll take time. People in our community are very clear on what the fire department does. They're really clear what the police do. They're not clear what DCC does because it's so new. DCC is going to have to fight for a place at the table to be heard because it will be really easy for traditional first responder apparatus to crowd them out and respond in traditional ways." So I think this gets at the challenge of doing something so new and patching it in the way Northampton is. Also, one perceived strength was really that having the DCC have a good relationship with those community members with very high needs to try to help them and get them resources where there's a real mutual trust. I think there's just a lot of situations where police and or dispatch feel helpless because there's only so much we can do. We have a lot of people concerned about people who are houseless, but it would be great to be able to have the DCC check on them. So this really gets at what some of the partners were hoping for potential strengths here. This carries nicely into the next set of data collection and analysis that we did, where we talked to DCC community responders themselves. These were, again, qualitative interviews where we tried to capture the frontline perspectives on DCC's development, implementation, and culture. This happened during DCC's first year. Again, we were really focused on identifying strengths and opportunities and challenges to try to feed that back to the folks at DCC. And I'll just highlight quickly that those were conducted during a big period of organizational change. And so, we learned about that through this process, and I think provided, an outside place to share concerns or, hopes as the DCC was navigating that time. So this happened in July of 2024. We were able to talk with 8 responders or lead responders in private semi-structured interviews, and then again using thematic analysis and a process that researchers call member checking, where we go back and share high-level findings with the folks who shared the data to make sure we got it right when you're taking the voices of someone else. So some of the results that we find fall into several different groups, and I'll just highlight a few of them. One piece was the challenging nature of the community responder role, which is abbreviated here as a CR. This is work that can be really emotionally demanding, meeting people, on some of their hardest days and often working with limited resources. So success was viewed as needing strong interpersonal skills, emotional intelligence, and sometimes lived experience really helped. This is dynamic and unpredictable day-to-day work that requires a lot of flexibility and rapid problem solving too. So when you think about feeding this into a process of hiring and training different kinds of people to different applicants to do this work, I think we can learn from the folks who do the job about where some priorities for hiring can fall. We also heard a bit about program and organization and structure pieces. And navigating leadership transitions and unclear policies, the kinds of things that are actually challenging in any organization at any time, are true also for community responders. And perhaps maybe even more so given the nature of the services that they're providing. But they noted a generally positive and supportive organizational culture and valued certain things like opportunities to debrief and actually talk at the end of the day about what they were experiencing and how to do better. So we'll talk a little bit about that in a minute. Um, Another thing they talked about was the importance of community trust and relationships, and the goal of DCC being reliable, trustworthy, and active resource in the community, and how to navigate the relationship with the police department and the DCC, recognizing that they also have to have trust there without alienating community members who might also hold a lot of fear. One of the things that I thought was super valuable coming out of this was actually asking the responders, what would success look like to you? Because coming up with metrics, when I talk to a friend, colleague about my role as an evaluator in a program like this, people are like, how do you measure that? Like, what do you look at? And we can think a lot about things like the 911 data, the available like services, the things I'll be talking about next time. But the responders themselves talked about and highlighted the importance of how it's complex to quantify success due to the breadth and the nature of these services that are provided. So they talked about things like the depth of relationship and trust with community members as a real measure of success, because you can't help people make the kinds of changes that really reduce the higher level needs and challenges without that kind of trust. And the importance of small wins as well as major outcomes, right? Like, for example, getting someone housing is a major thing, but so many small pieces have to come together. There has to be a willingness to, take action. And so the responders highlighted the importance of those pieces, which, I thought was super valuable to be hearing as we think about, how do you measure something like the DCC and its later impact. A couple of quotations here in the interest of time. I'm only gonna talk through one or maybe two of these, but we will definitely make materials available. I think I'll focus on the measuring success piece, because like I said, I think that's such a key aspect of how to think about evaluating the DCC's work. So they talk about the value of hearing from actual community members who have been able to receive support that's helped them. And I think, unfortunately, for this job, a lot of success stories, you don't always end up with everything's perfect. Some of the success stories are, we got them to that appointment. Now they're on a good path. And some of the success stories are that we don't see these people ever again because they've been able to just move on from the city. And I'll take a pause and say that feels like one of the most public health quotes that I have ever heard, because so much of prevention work and public health work is actually helping people to sort of move on from needing your support and help. So, I think that that's really an interesting angle. Okay. I will also share just one little tidbit about, how one responder shared that I like being within the community. It's important, especially with a lot of our folks that don't understand what our roles are. It's good to physically be out there, shaking people's hands, talking to them, treating them like human beings, talking to folks about issues that are coming up, trying to work with them in real time. Like, what are the ways we can find a resolution with each other together? That is the kind of time-intensive work that other entities don't necessarily have, but that can really move folks along to address some of the social determinants of health that allow some of the other problems that we encounter to eventually reduce. Okay, so I will also talk about, I think that was a really nice segue, because we were hearing from the responders about the value of hearing from clients themselves. And now we'll have a small opportunity to hear a little bit about our client interviews that we were able to do. So during year 2, this was August 2025, with the goal of understanding the perceptions of the services that the clients were receiving, we sought to gather information from clients. We did 19 interviews conducted both at the DCC's drop-in space as well as at Mana Community Kitchen. And so, as researchers, it was really important about, wearing this evaluation hat, it's really important to not only conduct your interviews in the place where a program is located, people may be less forthcoming about challenges if you only talk to them sort of in the place with the people that they're receiving services from. So I was really proud, again, that DCC was fully supportive of us going elsewhere and talking to people, not only at their space. So these interviews didn't take very long, about, on average, 10, maybe 15 minutes. And again, transcripts were coded and analyzed by our team. We heard about, in sort of one key category, we'd consider services in space. We heard a lot of clients talking with high appreciation for the kinds of administrative supports that they get help with from the DCC, applying for benefits, things like that. And also, there was a high value placed on mobile support. The DCC being out there in the community with their bikes and vans, helping people access resources right where they are. They also talked about the importance of the DCC having a physical space. That's another piece that's very unique in these kinds of programs. That allows, a safe, calm, consistent place to charge phones, connect, find community. And that's actually really important for people without stable housing or stable access to even a phone to try to get supports that they need. We also heard about characteristics that make for a good community responder. DCC staff were generally seen as people of action who get things done. And they highlighted things that are interesting to think about in the context of some of the baseline hopes that we heard, like strong de-escalation skills, both with community members and with police, as well as empathy and experience and sort of a confident presence of the responders, people who can get things done. We heard a few concerns about things like favoritism, and that really highlights a need to keep the program having feedback mechanisms so that if somebody is experiencing a challenge, which happens, this is just part of any service provision, there are ways to share that and then get response and get things addressed. So I think that's, again, one of the great values of an evaluation like this is feeding those kinds of things back so that things can be tweaked, right? And we also, did hear some clients expressing concerns tied to DCC being a city agency and would information be shared, so there's a learning and teaching opportunity there. And they appreciated DCC's collaboration with community organizers. And, we heard a small amount of information about like DCC is always out there and helping. And some people felt like, wow, they really know a lot about our business. So again, great opportunity to feed these kinds of things back to the program so they can establish feedback mechanisms. I'll share just two quotations here. One about the anchor support, because it's a privilege to be able to let the client speak for themselves in this way. So we heard that it's also nice to have a place to meet up with my social worker when we have things to work on. Like tomorrow, I have an appointment to go over housing stuff, right? Having actual safe places to do the kind of work that moves people along into things that really are going to improve their lives and improve the community. We also heard about de-escalation, saying, yeah, a lot of times, yeah, since DCC has been here, there's been a lot of situations where they've intervened before it got to the point of needing the police, which is great. And as someone like personally who has done some research related work in community violence and violence interruption, I'd love to hear that, because that's not what this program at its high level like says that they are, but that de-escalation opportunity and the trust that's required to do that kind of work is an incredible thing for a community to have. So I've shared a lot of things with you guys in a very short period of time. I'll wrap up with just sharing some of the recommendations that came out of the baseline and year one work that we did. And again, I'll come back in a couple months to share more. Some of the things that we shared, and all of this has been provided to DCC. All of this is sort of already being addressed. Just the lag of sort of, me getting here to share things with you. Uh, some of the things that we talked about included strengthening data and documentation systems. I've seen that happen, and I'm so excited to dive in more to some of the DCC's own data to help them with that. Continued investment in staff training and development, the work that they do to deepen trust building and community engagement. And I think this could go both for with municipal partner agencies and with the community. Um, some things that, I hope to see in sort of next steps would be, standing up those client and community feedback mechanisms so that if there are challenges, the DCC has like a nice active way to get that information. And also, planning for some follow-up, right? We've collected some great baseline data, and I'm hopeful that the city will be able to actually go back to the community and do some follow-up to see changes in the way folks feel about now that the DCC has existed. I think one of the tricky things that we're continuing to talk about is what is the right timing for that? Because you need something to be well established before you can look to those outcome measures. So thank you so much for listening to all of this. And here's some contact information for us. We'll open it up for Q&A.
Thank you so much. That was great. Very interesting. Anybody have any questions? Cynthia?
Obviously I do. But thank you very much,
I've
Jennifer.
been standing. I'm going to sit down now.
Actually,
Oh,
Professor, could you take down your slides so we can see each other better? Okay, thank you. Great, thank you.
yeah, thanks, Jennifer. I should stand up because I've been sitting down. Just a couple of questions. I'm going to be very interested in the part two, part of the presentation when I took down that one of the goals was to reduce unnecessary law enforcement involvement in nonviolent issues. And so the statistics or your findings on that will be really interesting to me. And that just leads me to, originally the DCC was a recommendation from the Police Review Commission report. Very different time, very different cultural context happening at the time. And so what's of interest to me is not only has that been a key goal of the program, that the DCC and its responders have also worked in areas like housing and addiction and mental health and behavioral health, et cetera, all these other areas that we knew contributed to police interaction, poor police interaction, but so that just gets me to, do we, is part of the evaluation process is to learn from some of the things that our responders learned about gaps in our community other than police, right? I mean, social service, mental health. And what do we do with those? Does your program kind of, it's going to identify versus make recommendations, I think. Does that make sense?
Yeah, I think it does. And I'm also looking to see if Michelle is still here. Because, I think some of that is a question of capturing like the right way to capture what DC is doing and then the challenges that they're encountering, which I think feed into that second part of your question. So um, I have some ideas for how, from a outside perspective, we could begin. And Michelle and I briefly talked about this, and we'll see where that lands in terms of actual goals for us together. But trying to stitch those pictures together, particularly for some of the individuals who are most likely to utilize or have contact with police, EMS type services, to find those individuals in the DCC records and understand what kind of supports they might be able to access and whether things are changing. I think that's one piece of it. And I'm sure Michelle would be very happy to feed back gaps and where are the points of frustration, where the responders feel there's so much unmet need.
Yeah,
Um,
yeah. Mhm.
and then I think the last piece is just that, yeah, we are also really looking forward to seeing that analysis come to completion around what's happening with the 911 data. And I'm happy that Ariel is on this call because she has been our lead person crunching the numbers and really thoughtfully trying to make sense of this. And that'll be a great conversation to have next time. I hope that answers
I'm
some of your questions.
Yeah, I'm really interested in the 911 data, obviously, but I'm also like, I'll just take housing. Um, what can we learn to prevent the houseless? I mean, public health is all about prevention and the responders must be dealing with so many of the same issues every single day and so frustrating for them. Probably it informs new training for them, but wouldn't it be great if their input can somehow be leveraged so that we can come up with some solutions. So that's all I'm just suggesting. So, but great work.
I would say, Cynthia, thank you for calling that out too. And I really feel like the burnout and fatigue that we see in our healthcare systems in general around gaps in accessibility is like perpetuated in this secular fashion of people really not being able to either maintain or access intermittently. There's so many barriers right now that are evolving too, especially with the housing crisis, as you named, because we have this, peak. We had a peak after COVID with eviction moratorium that was, taken away, and a lot of surge. And then we had that Massachusetts response, and then we've had those, resources taken away around our emergency housing for individuals available to us. And we've had all the federal changes within funding that have affected really significant local agencies like Craig Store, for instance. They always were a last minute line item to get funded from Governor Haley and the legislator, and now there isn't funding. So, we've heard about these pop-up individual resources. We just heard about one that opened with 16 beds. But again, like the criteria for cold shelter threshold went from 20 something degrees down to 20 degrees to now down to 15 degrees. So you have all these landscape impact changes at the same time as the responders are consistently doing this work that makes the job perpetually difficult, but then even harder based on the systems of care's accessibility. However, I would argue there's something interesting about, and what I would like to really get into measuring, and what I learned when Jen and her team were providing like the interim early year one draft evaluation of where things were starting to go. And really what made, and I spoke to this yesterday, we actually had a huge delegation of like, I think it was between like 17 and 20 people come from Pittsfield, the city of Pittsfield Board of Health chair, several board members, the mayor, lots of department heads. It was all like very cool. Like we had a tour of the community space, the resilience hub, and then we did a formal presentation. Meredith, myself, the mayor, John, Anna from DCC, Amy was there, as well as some of our other DHHS team members. What the questions were they were asking around housing too from Pittsfield. But one of the things that we see is that the more the challenge grows, the more innovative, and I use the word scrappy for lack of a better term, the responders seem to get. In that preliminary year one data that Jennifer was showing me about the DCC services was the more challenges we got, the more scrappy responders got finding resources and finding ways to get people into those resources with dogged pursuit. Like that part really, in my years developing and working with the DART program, and I don't in any way want to put Taylor McAndrew on the spot here either, but I think we've seen in programs and oversight in the substance use and prevention world, as the barriers grow, the more determined the pursuit of peers, harm reductionists, and I think in this responder role is about getting creative to help people access those resources. But what ends up happening is the negative consequences capacity gets tipped because if it takes you that much longer and more points in time of intervention or process to get someone into that, resource they need, especially substance use, mental health, and unhoused individuals, it means you can't help someone else and the capacity keeps growing at the same time too. So I want to say it becomes a value proposition of quantity over quality sometimes for what the 911 system has been experiencing and we don't want to perpetuate. I don't know if you want to say anything about that, Taylor, as far as the challenges go.
I think you framed it, the innovations and scrappiness is, yeah,
Thank
accurate.
you. The only other thing I would say too is the one thing we start to heavily lean on in this evolution too is as the state and federal resources get leaner and leaner, we start to require more of nonprofits and entities that are non-traditional. And I think what scares me about that is they're so intermittent and unsustainable that if we adopt systems, we train our peers, our recovery coaches, our harm reductionists to then adopt these as their practices, and then they're gone. Then that's the same negative unintended consequence to having a new resource that you can find success with and you train to, but now you're left with something that you have to start all over again. So I just want to name that too, is it's an evolving process. So the real time evolution of the work is so fast right now, and the way the world is changing and the needs evolving, that it is really hard, I think, for these long-term research projects. And that's why I'm so thankful we've had access to UMass. I mean, we meet monthly. We are constantly spending, it's a hard balance between getting them up to speed with what's happening in real time in this past month to what we're looking to try and measure over a period of time with an evaluator framework of research quality, evidence-based practices. I did want to say one other thing about what you mentioned, Cynthia, with the 911 data. I'm really interested in that data analysis as well because, and I've mentioned this, to have UMass taking that public health programmatic assessment and evaluation lens on top of what like the LEAP data did, which was kind of cookie cutter justice based 911 data to validate the needs, which we already had in Northampton. There wasn't a validation process to start a program. We had a Northampton policing review that said we are starting a program. If LEAP said we could solve the world or not. But what I really want to know is how we start to create value in what the DCC is doing that starts to speak to the economic savings on emergency departments and healthcare, to Medicare, what we're serving for veteran populations with the VA cutting back services, our elder services, our rural community members that are coming destination to DCC, or when, like, for instance, Holyoke does a sweep of encampments and removes unhoused individuals, how the population shifts and surges and what that looks like on the burden of the community responder role and the value that isn't quite there for a system yet to say you're doing good work. We feel that you deserve to be acknowledged in an economic framework as a professional role and as providing a valid service. So I really want to create that because I think that partially helps with the intensity of what the responders lift looks like day to day and with the systems making the work harder for them and yet still in this process of proving themselves, you know, like as individual people doing those jobs with dedication and passion. It takes a lot more than being, you know, fully vested to be able to sustain those ups and downs when it's really, really hard day in and day out, and you feel like the system's just making it harder, and they don't recognize how hard the work is that you're doing to try and help people from utilizing the system itself. So it is kind of a real passion of mine to try and look at the data in that way, as well as the causations, the root causes. I did also mention Taylor as well, because one of the process points of this in the evaluation, and maybe Jen, I honestly forgot to really think about that when we broke up the parts of the evaluation because it was so significant, was the DART program also evolved while the DCC was in its development so that we were best leveraging resources within the DHHS and as well streamlining our institutional processes for training and infrastructure and programmatic harmonies. And so when we did that and we brought the DART responses in, we actually looked to possibly be making changes within the way our police partners refer people for post overdose outreach, and that additional role that the DCC took on really came full circle as we are here to help you and support you around your substance use and your risk of overdose while this evolving toxicity of substances and the risk of all of the causes that injection drug use and drug use has, especially with the underlying justice and also other risk factors. So it's really opened up the door for more partnerships, I feel like, and more training opportunities and more cross training. How quickly that looks, and what I hope for our continued evaluation is that, for instance, that our program spent years developing a framework for educating dispatchers, law enforcement, and other agencies that are trained in the critical incident training the state requires now of police officers. That was a kind of optional program when DART was launching. And what now is an actual criteria is that the DART program come in and actually train all those officers. And I got a chance to go watch one of the CIT trainings in the Holyoke Academy, which had Air Force members, dispatchers, police, local and state, that all went through this harm reduction training and talked a lot about the Division of Community Care because DCC and DART are a shared program now. And we had a police officer there that was one of our leads talking about all about the value of the DCC and helping people that won't receive post overdose follow up, also encourage them to utilize the DCC resource and helping people get there, which was so amazing to see those programs kind of come full circle because we're talking about deflection from justice systems being taught by a police officer to other police officers. So there's a lot of system change that's happening programmatically, and that could underpinningly have impacts on the 911 system. So very exciting stuff. I could talk about this all day long. And I also really encourage you as our Board of Health to come to us with any questions around this for evaluation with other areas of social determinants of health that you are particularly interested in. But things like the kratom policy and the risks evolving, you know, the variety of different substances and risks for people, as well as the what you've had as declared states of emergency or responses by Board of Health for isolation, overdose. Like these are all those underpinnings that DCC is addressing, as well as what the Policing Review Commission tasked us with as a DHHS effort. So I'll stop there.
Thank you, Michelle. I think you bring up some really good points that have so many changes that are happening at the same time you're doing this evaluation over time, thinking that you want, in a way, for things to be constant and have the only thing changing is implementation of the DCC, but so many other things are changing at the same time. Yeah, makes it complicated. Any other questions? Janet, Suzanne, anybody else? Janet?
Yep. Well, first of all, thank you, Jennifer. That was a great presentation, and it helped me to really get kind of up to speed on what's going on. What I'm not clear about is there a time frame for when the evaluation will end, or is it completely ongoing? Yeah, because of course funding is always an issue. So
Well, that might be a question for Michelle. I can speak to the set of tasks that, were shared in this presentation does reflect like the completion of contracted deliverables. And we have lots of ideas on things that could continue to happen to strengthen the ongoing understanding, right? I mean, as you make the good point, like a program being implemented in a very changing environment, it's hard to pick a point and say, this is over and we know, this worked or this didn't work. So I guess what I would say is I think there's opportunities to build on what's already been happening and for there to be ongoing assessments that help get to, what I'd love to see if I could dream about next steps is as we wrap up those, 7 things that we talked about, we'll come and share about that next layer about understanding economic impacts. Like, I feel like there's probably a few core key things that would be really, really good to see happen to leave the city feeling like we understand what happened, what didn't happen, what the value proposition is here.
so currently then the work is done for now, is what I'm hearing.
We're wrapping up a few things.
You're wrapping it up.
And there
So
are
that
some
means
ongoing conversations about next steps.
Right. So those meetings will end unless a
Well,
decision is made and there's a possibility to kind of implement some of those next steps.
I can share some good news and also some aspirations. When we mentioned at the last board meeting, we have put in a proposal with the Office of Behavioral Health Prevention and Promotion. We built in areas for evaluation. Granted, that particular project will not focus on DCC entirely. It was to provide some leveraging of braided funding and resources as well to continue the overarching. Then we have a SAMHSA FR CARA grant that's currently, it's FR CARA, right, Taylor? I don't know why my brain was like,
Yeah.
that we're waiting to hear on. We were supposed to hear in September, and then with the federal shutdown. And just today, we actually put in one of our final deliverables for our second FR CARA. That felt really weird when I was writing final.
And just
Yeah.
if I could hop in, Michelle, I think that's where mentioning the integration of DART is really important because there was a lot of availability of funds and historic precedent of DHHS having these federal grants that focused really acutely on opioid use and overdose. And then they've started to kind of grow out how we look at interventions in the community related to addiction. And so by having DART's mission really for the better be carried out by community responders has, as Michelle mentioned, that braiding of funds be pretty seamless.
In addition to that, we did get some news on the EAPS funding, and unfortunately, it's definitely not the annual award amount. And thank you, Taylor, for mentioning that because there is some new actual post-overdose or overdose response opioid risk related grants that we're seeing and we're aware of that are also coming down the pipe. So we're always looking, but we do have a component of the award that we should be getting at minimum from EAPS, which is less than half of what the award was annually prior, that we've already committed and dedicated. Will include a line item with the budget we submitted to DPH. And then I think we've also gotten a few other grants that have a few other components. So we might be piecing some things together. But one of the things Meredith said yesterday when the city of Pittsfield was visiting was how difficult it was for us up front when we were first getting the EAPS funding, and we had that small percentage of inherited funds that came to us from the early start of the Department of Community Care when DHHS was formed, and having to commit 10% of that budget to evaluation was really difficult. And she said, when we needed warm bodies and we needed all this stuff, we really had no choice. And her and I were like constantly like, how are we going to create the evidence that this is impactful from public health, and before we were under public health attack to the extent we are now. And I just felt so strongly there was going to be no other way unless we built the evidence-based practices, that the justice system in its efforts is perpetuating its own narrative in many cases by self-assessing, self-evaluating. Even 911 data is evaluated by justice, the law enforcement action partnership, even the lens they try to take that's somewhat neutral. We as public health have to demonstrate this because no one is going to demonstrate something new for us. So it's an onus the mayor's been very committed to, and so has Meredith said out loud, I am so glad we did. And we are committed to continuing this. And she was highly advising Pittsfield to do so as well. And so I think there's a lot that we are going to do, and the commitment is by DHHS. And if we have to try and move this to that funding to this funding, we've already, Jennifer and I talked about some range of a scope of work to get going for this year now that we've heard from EAPS. The other thing I want to say is there's the component of my aspiration, hope, a dream, and Jen and I are on the same page, and so is CPE's leadership to Elizabeth Baritone Johnson. We'd really like an NIH study, and we'd really like to get a bigger long-term federal funding commitment that could help us to look at this as an infrastructure and from a federal level. My goal and my secret dream is that DCC is adopted as a DPH intervention and they commit to it as a resource and scalability in the future for other communities to be able to take this on, because we know these problems are not going anywhere. We've seen the assets and deficits of co-response and the subcontracting by DMH to agencies and the variety of challenges that come with that. In this freestanding public health approach, it's going to keep coming back to us in public health with social determinants of health to solve and address the issues. And so we really want to get ahead of that. And I'm hoping the Board of Health can be our key to that. And not looking to preempt anything, but with our public health authority and with the innovation this board has put forward in Western Mass as practices that have been adopted by Eastern Mass all the time in my time with the city, that we can somehow create policy recommendations and even a letter requesting DPH Commissioner and or Maura Healy consider this. I also would love to look at this as a statewide opioid settlement fund in part, because we are addressing those risks, and that might be a good use of state funds that locally our own community member is designing through their responses and surveys interventions, but this would be a great state initiative to potentially invest into. So lots of ideas, and we're open to any. You have to.
Thanks, Michelle. Any other questions for Jennifer or about the evaluation or anything else? Well, we appreciate you coming and your whole team being here and for the great work that you've done. And we're all, I'm sure, really looking forward to part two. So,
Thanks so much for the opportunity.
yeah, it was great. Anybody else, any other comments or questions before we let you go? Okay,
Thank
thank
you,
you so much.
Dr. Levin, too, for allowing this to be so comprehensive. This was important, and we were afraid to push too much into one meeting, and you graciously made
No,
sure.
that actually worked out great. You know, I think doing part two and the 911 stuff would have been just too much for one meeting, but
Yeah.
we look forward to hearing more.
Powerful Board of Health we have here that supported this work all along. Thank you, everyone, for your time tonight. We
Thank you.
appreciate it.
Thank
Thank you.
you.
All right, take care.
All right, we're going to continue our meeting. I think the only thing else on our agenda were the minutes. Did everyone have a chance to see the minutes?
Um, This is Suzanne. I did, and I don't have anything to add.
Woo!
Nice job. I thought you screamed, Joanne. Thank you, Kelly. What a
That
nice
was
job.
Kelly's doing, yeah.
I try.
I know you do. I know you do. I know I make you crazy. Thank you very much.
Anybody else? Does
I'm good.
anybody need to see it again? Would anyone like to make a proposal?
Move to accept the minutes.
Is there a second?
I'll second.
Okay. Any discussion? All in favor? Suzanne?
Yes.
Cynthia?
Yes.
Janet?
Yes.
Joanne? Yes. Excellent. Thank you. I think there's nothing else on our agenda. Our meeting in January,
January 15th.
that's the third Thursday in January is the 15th. Can everybody attend? Do we know? Does anybody know? Sounds
Yes.
good. Great. And I think at that meeting, we'll be addressing or starting our discussion of nicotine-free generation. If you have other things you want put on the agenda, please let me know. Does anyone have any other questions or comments before we go?
I missed the commissioner tonight.
Janet started to speak and then she
Yeah,
stopped.
I mean, I was interested to see in the paper that the Cannabis Control Commission looks like they're going to be moving forward with on-premise sales, and interesting how they've broken it up into different kinds of licenses. And to my knowledge, we are not involved in that at all. I guess I just kind of wanted to say, yeah, it's going to be very interesting, and I'm concerned problematic as it moves forward on all kinds of levels. The way they talked about municipalities needing to be in control of certain regulations, it seems like they're putting a lot on that. I'm assuming they mean city council. It just might open up a big door.
I think it sounds to me like it's similar to the dispensaries that had to have an agreement with the city. And so I was thinking that I don't think because it's run by the Cannabis Control Commission that we are allowed to intervene. On the other hand, if we wanted to give some input to the mayor or to city council, some thoughts about things they should put in the contract that would relate to public health, I think we can think about that. I'm not sure what exactly we can do, but my biggest concern is impaired drivers. And I'm not
Me too.
what they can do about that. Taylor?
If I could just ask
Oh.
one thing about it, I mean, is part of it that we would go through, and you may or may not know this, but we'd go through the same process in terms of, or the city council would of approving a number of, how many are allowed in the city? I'm just wondering.
I think that's a different issue. I don't know if that would be in the sort of agreement or the framework that the city would develop. Maybe they would now that after having the experience of the dispensaries. But I guess that's something else we could comment on. Taylor, did you want to say something?
Yeah, thanks so much for bringing this up. It's kind of why I stuck around. I just wanted to say this is something that the leadership talked about earlier in the week, because it's this intersection of the environmental work that Amy oversees, the prevention work that my team is doing, and that there is a lot of folks in the region who are gathering to discuss public health implications and roles that municipalities can play. So just to say that, like, I'm on it, we're on it, happy to share whatever information we see. And to also say that right now it's interesting because the draft regulations came out this summer. I was able to look at those. I think it's January 2nd or like in the next 2 weeks or so when the final regulations come out. So up until this point, we're not even really sure what made it into the final, and that there were some public health allies and advocates who, around smoking, around things like driving, the training that's involved, they were really pushing to see some changes from the draft. So I think until the final gets published, we're all just kind of like waiting to see how things shake out.
Thank you. That's great. So I think I'll talk to Meredith about bringing some information back to this group.
And I'll add, Meredith has reached out to Cheryl too, to get her to come and provide the information that she knows.
Joanne, if we could think about last time when the idea of how many places should be in the city, we just weren't very proactive in all honesty. And I think we have something to contribute once all the, like Taylor's saying, the final document hasn't been produced yet, but the municipalities have firm control over how it will be implemented and how many and what. And we don't have a say in that. And well, we can advise, but it's out of our bailiwick to have a policy about it.
Right.
And so, you were talking about driving. I'm thinking about inhaling, which, smoking in a confined place is something we have a regulation against. So I think it'll be good. I think it'll be over a year before it really kind of comes into place. So that gives us some time to look at the document. But it'd be nice for us to be proactive this time around.
Yeah, I agree. I don't think we can make a regulation, but I think we could make recommendations to City Council, to the mayor's office. But yeah, I totally agree. Thank you for bringing that up, Janet. Anything else? Well, wishing you all wonderful, wonderful holidays. Thank you for all your great work, Michelle, Taylor, Amy, Kelly.
We need a motion to close.
We do.
Move to close the meeting.
I second it.
Excellent. Any discussion? All in favor? Janet?
Yes.
Cynthia?
Yes.
Suzanne?
Yes.
Joanne? Yes. Thank you all. Wonderful holidays, and we'll see you in January.
Thank
Good
you.
health.
You too.
Thank you.
See you next year.
Bye-bye.
Thank you, Kelly, for everything tonight.
You're
Everybody be
welcome.
safe.
You too.